Well, good evening, everybody. Thank you for coming here this evening. My name is Bob White. I'm Director of the Faraday Institute. And we have one of these public lectures every term, but we're very pleased this year that it coincides with a weekend course, which is going on. So we've got lots of delegates from that as well. So thank you all for coming. We'll have a lecture. We'll have plenty of time for questions and answers, I hope. Then there'll be a reception outside and a bookstall before we go off to dinner afterwards. So that's the plan. It would be very good to switch off your phone, not least because this is being recorded and your very strange ringtone would be recorded forever then if you've not got it switched off. One of our speakers had a phone which said, "Hi Dad, hi Dad." I'm sure none of you have anything like that. Let me introduce Professor Irene Tracey. She holds the Nuffield Chair of Anaesthetic Science at the University of Oxford. And I'm not going to read out all her honours because we would not hear from her then because it takes so long. But she was an undergraduate and graduate at Oxford, and then she went to Harvard Medical School for a postdoc. And her research and her team has mostly been working on pain perception and pain relief, the sort of things that we're going to hear about tonight. So she's an expert in that. And in '98, she founded, with another person, I think, the Oxford Centre for Functional Magnetic Resonance Imaging of the Brain, which is quite a big outfit. There's over 100 people in it. And she was directing that until this year, I guess, before you move on to something new. That's enough from me. Let's hear from Irene. Thank you very much.
Good evening. Thank you very much for the introduction, and mostly for the kind invitation to come and speak with you this evening. I decided I'm going to give you a little bit of everything, and I'm conscious that you want to get to wine and have time for questions. So if I skip over slides, I apologise, but I want to make sure that we have time for some discussion. And so what I thought I'd do is tell you a little bit about really the history of the brain and how we've approached understanding that the brain even is the organ from which our complex perceptions and experiences and what makes us who we are arises from. And then we'll touch a little bit on pain and what we know and how we're thinking about pain and how we've been imaging the intersection really between belief states and pain and how religion might come into that. And I've been asked to sort of interweave as I go along my own views and thoughts from my own personal background as a practicing Roman Catholic and somebody who is a Christian and has a faith, and so again how that impacts my science and how I think about things. So I hope that's what you're expecting. If not, please leave, because that's what we're going to talk about. Okay, so pain, first of all, just thinking about the pain side of things, it's a very normal thing, isn't it, to experience pain. We've all had pain in our lives. I hope none of you are suffering from chronic pain, but we've all experienced the good, everyday, warning pain. And so it's a very perfectly normal part of living organisms to experience pain and to suffer. And one can trawl the internet and pull up, an array of different pictures that again captures both the injury element of pain and then the suffering that goes with that. I think what you should also be reminded of is that pain, of course, is one of our oldest sensory and emotional experiences because it's just so very important. So if we think about what we actually are as decision-making bodies, where we interact with the environment through our senses, we see, we hear, we smell, we taste, we touch, we experience pain, then we make decisions about what that is and what that means in the context in which you're experiencing those, and you make a decision and you act and behave back out in society and with the environment. And that, at one level, is, if you're very reductionist, what you could reduce down living organisms as being little decision-making things that perceive things. And if you think about all those perceptions we have, pain's a really important one and a very old one, and that's why it's so shared. And we see it in the most simple of organisms through to complex humans. So what I've illustrated here is a sea slug, a very simple organism called aplasia, and what that sea slug is doing is releasing a dye in the environment because something in the environment is potentially threatening. Something in that environment might actually not only just hurt it, but potentially kill it. And so in a classic, what we call nocifensive reaction, very similar to if you touched a pan on the stove, you'd withdraw, if you stood on a drawing pin, your foot would rise up. That sort of nocifensive reflexive action, this is what the sea slug is doing in order to cloud the environment so that it can basically hide from the predator and get away, because that's the decision it's made. Now, so we've got an old experience, we've got a shared experience, and it's a very important one. And the problem we have in understanding pain, even everyday good pain, let alone chronic pain, is that we really can only understand somebody else's pain by inferring what we see in them in terms of their behaviour, maybe the way they describe their pain through language, if they have capacity to speak, with what our own pain journey and our own pain story has been. And that sort of pattern matching, if you like, is subject to all sorts of biases, because we make judgments, don't we, about, well, really, I don't think you should be in that much pain. I mean, when I had it, it wasn't anything like that. And so we bring all these different biases and beliefs about what somebody's pain should actually feel like, and judgments. And of course, that's very problematic. So where do those biases or beliefs come from? Well, they come from basically all sorts of implicit messages that you grow up with without probably realizing. So again, I've just put a few up here. We have obviously a very rich heritage in our religions for suffering, martyrdom, pain. We have many images bombarded for our sons and our men about the fact that there's no pain without gain. It's good to be tough and machismo. I can take it, I'm not going to let this beat me. We have lots of indoctrination that women should suffer in childbirth. Somehow that's good for mother and good for baby. Never bought that one myself and my 3 children. And we even have our great men of literature. If you take a quote here from Dostoevsky, pain and suffering are always inevitable for a large intelligence and a deep heart. The really great men must, I think, have great sadness on earth. So again, we're just sort of bombarded with all these images and influences that put us in a certain place in terms of what we have as our attitudes, our biases and our beliefs about what pain people should really be having. So when we come to a scenario like this, I'm going to challenge you now. If we take the little old lady on the right-hand side with a horribly twisted, rheumatic hand, and you saw that picture and that little old lady was sitting here and said, excruciatingly painful, we'd all be fully empathic, compassionate, and we'd want to help her. I bet you, though, you'd also be just as comfortable and okay if she actually turned around and said, actually, it doesn't hurt at all, it's perfectly fine. I manage fine, I bake, I cook, I do all my usual things. And we'll probably say, good for you. You're a tough old bird. We don't build them anymore like that. You know, the great sort of war generation, they're tough and they're hardy. Yes? Am I right? You sort of feel that that would be a similar combination. Let's take the picture on the right-hand side. Again, we're very comfortable in our sort of medical model of what we see, what we get, but that person would say, actually, this doesn't hurt. My hand is perfectly normal. It fits with our model. But if they said, actually, I've got excruciating pain, let's imagine it's a sort of middle-aged woman like myself, and saying, actually, I'm in absolute agony with this hand. We'd be, really? I'm not quite sure I buy that, and we're not so comfortable because you're bringing those biases, you're bringing that model that if I don't see it, then I don't believe it, and you're not being fair and objective in the context that actually, as you'll soon learn, it's a long journey from where the injury happens to where the brain receives the signals and produces pain, and many things can change on that journey. So you can have what we call a 2-by-1 combination, pain, no pain, equally with that scenario. As we translate out into more clinical conditions that we, again, still struggle to understand in the context of chronic pain, fibromyalgia, irritable bowel syndrome, a lot of patients are disbelieved about their pain because we can't fit it, we can't see it in our medical model that requires we want to see physical injury, and then that equates linearly to what the person is saying. And what you're doing there is unfortunately bringing those biases to the table. So again, we've been using imaging to unravel behind the scenes what's going on, and using more independent ways of analysing the data. So you can take me out as the expert, so I don't have to interpret these brain pictures, and then it can just be done automatically. And that's basically what we're doing a lot of science for, and will be hopefully rolled out as we go forward in the years to come in the NHS. So acute pain's good. Acute pain tells you something's really bad, potentially might kill you, you better get away, you better attend to it, you better discriminate how bad it is, and you better decide and act. And that's what you do. If you think about just opening an envelope, and if you had a paper cut when you've just opened an envelope, in an instant, if that sharp cut you locate, it's a mechanical, it hurts. It's not so bad, okay, I'll carry on opening the letter. It's not that bad that it's going to distract you and fall on the floor. So in an instant, you make all those decisions, and that's, of course, the protective element of good acute pain. Chronic pain, however, is pain, it is defined as pain that outlives the normal tissue healing time, 3 to 4 months. And it's pain that's gone wrong, basically, so the warning thing's done its job, and now you've really transited to a very different place, actually a very different mechanisms behind it, a very different disease, if you like. So it really bears not much resemblance to what initially caused it, and it shares many similarities with many different types of chronic pain conditions. So it's the system gone wrong. It's actually one of the largest medical health problems that we have. And for those of you who are interested and would like to sort of just get a Hollywood version film of what it's like to be in a chronic pain state and the suffering that goes with that, and particularly the US angle, the problems of overuse of opioids and getting hooked on opioids and over-addicted. This is a film which Jennifer Aniston, I'm not, she's a good actress, I'm not plugging her, I don't have any shares in this film, but it is a very good film actually. It's interesting for Hollywood to have picked up on something like pain, because often that's sort of sidelined a little bit, and again, considering how big a problem it is, we don't really see or discuss it much in the public. And again, I think that's quite a good film for really going into a couple of individuals, extreme suffering by living with this condition and the consequences of that. So as I said, it's a big unmet need. 1 in 5 of the adult population are defined as having chronic pain. On average, the sufferers, I'm afraid, they live for 7 years with it, and 20% live for over 20 years, so that's pretty much their life consumed by this condition. Losing jobs, there can be marital breakdown, problems in relationships, and the cost for society, if you don't know about sort of health economic costs, these are very, very big. So if you look at the USA, the cost of management and treatment and people not going to work because they have migraine, backache, neck is $600 billion per annum, and in Europe about 200 billion euros. So a very expensive condition, and I'm afraid we're not very good at treating it. So if you look at this chart here, you'll see that most of the drugs we've got don't work, and those that do only work a little bit in terms of bringing relief. They don't bring full relief for the patients. And so you can do the math and realise there's an awful lot of people out there just living and suffering with this chronic pain, seeking alternative ways for them to manage and cope with that condition. And I think, again, that's where learning how we have other ways of bringing other types of endogenous, inbuilt systems of pain relief to the fore is what we're going to talk about a little bit, and that's where the intersection comes with belief. One of the reasons that is so bad is because we've actually had the wrong model to think about pain. We've very much treated it as a continuation of the thing that caused the good acute warning. So we've been trying to fix that, not recognising that when people have transited to a persistent chronic pain state, that's actually a very different thing with different mechanisms, and we have to understand them, and they're the mechanisms we have to target. So that's, the good news is the new science in the past decade has now got a much better handle on what those mechanisms are that underpin chronic pain. And there's lots of really exciting new targets, and there's lots of novel compounds coming through the drug discovery pipeline targeting that new science. So I think going forwards for our chronic pain sufferers, it's going to be a much better place, and that we'll have really, really radically different ways of trying to help and dampen things down and switch it off and reverse these processes. So that's just a quick snapshot of sort of pain and where we're at. Let's go back to the sort of brain bit of it. Good old Hippocrates, who has a quote for pretty much everything, if you want one. This is now, let's remember, this was hundreds and hundreds of years before we actually really, in the 1700s, worked out the brain probably was where perception arises and is the seat of reasoning. Back in 460 BC, without any of that knowledge, he put the brain as the seat from which really, really complex, subjective, private experiences like joy, sorrow, grief, and he put pain as being things that the brain probably produces and the brain alone. And it's absolutely remarkable, because we've gone through all this time from antiquity where we sort of thought the ventricles, you've got these incredible pictures here on the top left, where you can see these ventricles were drawn in, and they were filled with fluid, and they thought at one point, well, that's liquid in the sort of brain spaces of the brain, so probably that's communicating with the rest of the body. It makes sense, it's all about the ventricles, and that's just fluff, all that grey matter, just protecting those precious, precious ventricles. We've even got Leonardo making beautiful wax casts of those very ventricles, and again, attributing specific features of judgment and sensory and vision as they pass through the different gaps in the brain filled with fluid, passing on the information. And you can again go back and look at the debate that was waging, throughout this time. Is it in the brain or is it the heart? The heart was something that was pumping blood around the body. So again, it made sense that that was probably how you communicate with the environment and brought it back, and that's where the decisions and the perceptions were arising. So you can see a quote from Shakespeare here, tell me where is fancy bred, or in the heart or in the head. It still wasn't really quite understood where is the seat of reasoning. So we eventually got there, and again, I'm not going to spend too much time going through the history of neuroscience and the brain. That would be another lecture completely. But we come to Descartes, who, from a pain perspective, is very important, and also I think from a medical perspective is very important, because at this point in time, what he did was made that radical distinction between the mind and the body. And that was great, because it freed scientists to go and actually explore this organ and understand it more specifically without getting into trouble and without the problems of, again, people being devout and practicing and feeling that they were sort of treading on the footprints of God. The problem with that is it brought about sort of dualism, and again, we can maybe go into that a little bit at question time, about how I think in particularly complex experiences like pain, where we still have this very dualistic approach. It's in the mind, it's not real. And we just had this big push, haven't we, about mental health in the country. And again, there's a lot of dualistic thinking that I think holds medicine back. And a very nice quote from Kinnear, who's a very excellent physician, said this antithesis between something organic, again, something that we're comfortable with, it's structural, it's physical, I can see it, and functional, where it's all a bit in the mind, all a little bit weird. Disease states, it still lingers at the bedside, it still really holds us back in bringing actually all of this together as one thing that again is physiology. I'm thinking again from the science bit at this stage. So Descartes was very important for that reason. He's also very important from a pain perspective because he, again, informed by Hippocrates, put the brain on the map as being probably very important. There's this classic picture that Descartes drew, which is of a boy who, for whatever reason, put his foot into a fire. And because we didn't know about synapses and wiring at that stage, it was considered probably some sort of hydraulic system that pumped fluid up, and it rang a little bell, like a servant's bell. I want my cup of tea now. So you ring a little bit of bell in the brain, and that tells you it hurts. And to a large extent, you could criticize what I've been doing is just putting fancy pictures on that model. But that model is what we call a very bottom-up model, and it's still the model we teach our medical students and our scientists in terms of the pathways for pain. So most things that everything that you have a sensory experience of is built what we call on a 3-neuron order system. So you have one of the neurons out there in the periphery interacting with the world, and in pain those are called nociceptors. And generally, if you think about pain and painful experiences you have, there's 3 broad categories of pain that you have. One is the thermal type, being burnt, being frozen. One is the chemical type. You've all, I'm sure, chopped chili peppers and then rubbed your eye and really, really regretted that, yes? So there's the chemical types of pain. And then there's the mechanical, the pricking, the cutting, the crushing. And so those come in, and then they basically connect in the spinal cord to another neuron, and then the other neuron takes it up into the brain, and then it goes into different regions. Now, why am I showing you that? There's 2 points I want to make here. The first is that that's a long journey, and pain's old. It's had all of evolution to fine-tune that journey, so that what you get there at the periphery and what actually ends up upstairs in your brain can be a very different thing. So there's what we call non-linearity between what you see and the damage out there and what the person actually perceives and describes can be very, very different. And that's why that model of if I don't see it here, or if I see too much here, and it doesn't relate to what the person's telling me, that's why that model, that non-linear model is the one you've got to engage with, and the linear one doesn't work, the Descartes one. Because throughout evolution, we fine-tuned all sorts of extraordinary changes, chemically, genetically, wiring, that can turn it up, it can turn it down, and then it can change where it enters into different brain regions. So you can exquisitely modulate what has happened at the start to what actually ends up at the end game. And don't forget, pain only arises when the brain gets those signals. Underneath that is just nociception. Yep, so you've got to have a conscious brain to experience pain. So we've got this incredible array, and that firstly just explains to you why there is this non-linear relationship, and you can't second guess from what you see to what you get. But also, the second point I want to make is actually that's not how the brain works. This is what we call a very bottom-up approach. So you have to think about it for an instant and realise that's a terribly inefficient way to build a brain. What we're saying is that's just sitting there as a receipt organ. All day long, it's been bombarded with lots of sensory things, yes? And then I'm processing them, experiencing them, deciding what they mean, and then interacting back with the world. It's a terribly inefficient way to do it. So it doesn't work like that. So the new way that we tend to think about the brain, and this is, I think, important because it gets into interesting discussions, maybe philosophically, but it's important for different understanding of clinical states that we've just never really understood, is that the brain has what we call priors. It's a Bayesian model. The Reverend Bayes, he was a vicar, but he was a brilliant statistician, and he had these mathematical, statistical ideas about how what has happened before will inform what will come later. And it was a sort of statistical way of thinking about things. So these priors, bias if you like, will predict a certain probability of the next event being like this, or being perceived like this. So the way we tend to think about how the brain works in the modern 21st century is a Bayesian brain, after Reverend Bayes, and this idea of priors. So let me give you an example. I'm going to touch now that glass top table. I'm a 49-year-old woman, and I've touched a lot of glass in my life. I have lots of priors in my brain about what that glass is going to feel like. So those are going off already. I now touch the table, and it's the combination of the bottom-up input from the glass and my prior expectation of what that sensory experience is going to be like. And those two combined, that's the perception I have. And that then suddenly is very efficient, isn't it? Because we can have priors, we can short circuit, we can have expectations. So that's a really efficient way to build the brain. That's how we tend to think of it working. Of course, what happens if those priors go wrong and those priors outweigh what's coming in? And they override, in fact, the bottom-up sensory input. Well, then the prior will dictate the experience. So suddenly, things like hysteria, panic disorders, I think maybe some pain conditions, where the priors will override what's coming in, and that model allows us to understand some of these conditions in a new framework. Now, we might have this framework wrong, we might change our minds in 10 years, but right now, that's the sort of way we're thinking about it, and I hope that sort of makes more sense, that that's probably how the brain works, yes? I mean, nods. Yeah, good. And let me just show you as a sort of cheat way of explaining these priors. These are not priors, so I must be very clear there, but it's a good analogy to potentially show you about how the brain has got this capacity to have priors. And that's by showing you this data set. It's actually what we call resting state data. So it's taking a group of you, putting you in my scanner, turn the lights off, no sensory experiences, and we just let you basically try and empty your minds and think of nothing. And you might think the brain is just going to sit there chugging along, a little bit of glucose usage and other things, and not very busy. Well, this is what your brain is actually up to. You can see you've got an extraordinary amount of highly coordinated, highly spatially organized network activity. And when you interrogate those different networks that we've color-coded, you see that those are networks that seem to look very similar to the networks we see when you attend, when you have a memory, when you move, when you touch something. So all the basic networks that observe what we do, we can see active at rest. And again, you can think of that as a sort of way of just showing you, one, how busy the brain is and how it's sort of working. But even when you're not having those sensory experiences, you're accessing, you're turning on, you're ready to go with those particular networks. Does that surprise you that, yeah, it's that busy? So that's a sort of indirect way of sort of showing you about these priors. So this nonlinearity, I'm just going to show you two extreme examples to drive home this message of nonlinearity. Here's a chap who, and this is true, there are people who have a lot of body piercings, and a certain group of them enjoy meeting at weekends and they hang from their body piercings. They actually not only don't find that painful, they find it a little bit pleasurable, and that's another story, maybe. But I look at that and I say that's a lot of nociceptive damage, that's a lot of input, and yet that is not relating to a high pain experience because of that journey. They've got incredible systems that we're going to come on to in a minute that can top-down block it, so they just don't feel that as painful. The counterexample is this one. This is a true story of a builder who stood on a nail. In London, he was rushed into University College Hospital, crying and writhing in agony. And when the nurses carefully opened the boot and they took the laces off and they opened the leather and they cut it, they saw the nail had gone between the big toe and the second toe, and there was no damage whatsoever. But the mere threat, the mere fear, the mere belief that that nail had gone through the foot was enough to switch on regions of the brain that produced painful experiences. So there we have an example of no nociceptive input, but very high pain report. So just again to stress the non-linearity. And again, what we can do with imaging is in effect create scenarios in our scanner on people like you whilst we're burning away, say with a thermal burn, and then we might change your mood. We might make you sad, we might make you anxious, we might distract you, we might make you reattend to the pain. And then what we watch is how to the same burn, your experience of that changes, that we're driving that non-linearity, and then what we're seeing is a change in the brain activity. Now I'm not a Pixar, illuminator, I'm not, it's not Hollywood here, but that's as good as it's going to go, guys. So that's it. So the same sort of, 48-degree burn at the back of your hand or poking you with a pin, I can change your experience to that same input like that. And I'll give you a couple of examples of how we do that in a moment to walk through the experiments. And so what you're doing is you're changing the context, you're changing the mood, you're changing the substrate of the brain into which those signals are coming. You will change the experience. And why do we have that incredible capacity? Again, I think it goes back to sort of the evolution piece, that it confers an evolutionary advantage. If you can have the pain that's appropriate for the situation you're in, you're going to make the right decision as to what to do about it. So the analogy I'll use is a lion bites your arm off. Two options. You can lie there writhing in agony, but that lion's going to kill you. So we've built incredible capacities in that high arousal, high fight or flight situation, that top-down systems will top-down block the processing of that damaged arm input that's sending in a big nociceptive barrage. And these top-down systems now just block it. So nothing comes in, you don't feel it as painful. You get up and you run and you get away. And then of course, when that high arousal, high threat, high fight or flight situation is over, the top-down systems get relaxed and the floodgates open and in goes that signal and you realise you're in agony. So we've got these incredible systems because they can drive the right behavioural response. That's probably why we have them. Okay, so we've got all these amazing tools. Most modern imaging labs like ours in Oxford, and ones certainly here in Cambridge as well, colleagues here that we collaborate with extensively, we can do an amazing amount of different things and collect amazing amounts of different information from your brains and your actual spinal cords as well, where we can look at your neurochemistry. Have you got a brain that's very excitatory, or are you a little bit more inhibitory? And just subtle differences in that. We can relate to differences in how fast you maybe make decisions, or how fast you have movement responses. We can look at, again, these resting states. How healthy are your resting states, your different networks? And again, in very early onsets of disease, we can see subtle changes in the conversations between those networks that can be very informing. We can do tasks. So we can, again, map which bits of the brain do all the different things. And we can look at the wiring using other techniques like diffusion imaging, where we can look at how well wired up are you and how well does that wiring confer the capacity to make those networks work. And again, we can measure that wiring integrity and see differences in that. Again, relate to differences in what makes us all very different. What makes somebody able to pick up a new musical instrument and have great motoric ability, and somebody not so good, not such a fast learner. Again, so we're relating behaviour to structure and function, and we've got an unprecedented now capacity to look at all these different things, and we are doing that in the individuals. So how does belief then intersect with pain at a mechanistic level? Well, let's go to an old part of the brain, which is one of my favourite bits, and we've done a lot of work on that, and that's called the brainstem. So you've got the spinal cord coming up, and then if you just look at where it sort of bulbs a little bit there, this is called the brainstem, very old brain, very shared, very low level. It goes up into the cortex, all the fancy bits. And we've got this dedicated system, the pain system, called the descending pain modulatory system. And its job, and it's unique to pain, you don't have it for any other sensory experience, but it's there because you need to have the pain that's appropriate for the situation you're in. So what you do is you top-down drive that system in two ways. In a descending inhibitory way, that's what you're tapping into in that fight or flight response. It's what you tap into when you're distracted from pain. We'll come on to placebo in a minute. And unfortunately, it's got a facilitatory arm which tops down, turns it up and makes it worse. And it's actually very interesting, a lot of the work we're doing now is showing how the imbalance in that system is very important for deciding who ends up in a persistent chronic pain state or not. But that's another talk that's more about the pain. So you can think of it as good cop and bad cop, okay? And you want to have lots of good cop and not so much bad cop. And again, there are so many situations in our life where we need that endogenous free analgesia. Again, different situations, different scenarios. Obviously, you just have the World Cup, many different nociceptive inputs, as you can see. Commonly, tactics that are being used left, right, and centre. Battle, going to the dentist, having your injections. All these scenarios where we psych ourselves up for pain relief, or where we're just distracted. So a lovely quote from Einstein here: when you are courting a nice girl, an hour seems like a second. When you sit on a red hot cinder, a second seems like an hour. That's relativity. It's very clever, because what he's done there is it's all about this, the context, really, in what you're in. But really it's tapping into the fact that if you're distracted, it doesn't hurt so much. Okay. And then, of course, there are these extreme people who walk on hot coals, they'll lie on bed of nails. And what is it that they're doing? Well, they're tapping into that good cop. They're driving, so you can think of it as the brain, and on the front think of it as like a driver in a car, and they can press the accelerator down and drive through that brainstem, that good cop. Block the input, so nothing comes in. And that, again, we've done a lot of work in that that's shown that's basically the system. It's powerful, it uses endogenous opioids, we know a lot about the neurochemistry that controls it. It's what you tap into in that fight or flight, when you're distracted from pain, reading a book, listening to some music, watching a good film. It's really, really powerful. So, of course, the ultimate endogenous analgesia is the placebo effect, which has had a very interesting history, as you well know. And the question for a lot of us is there anything really special about placebo analgesia, or does it just hijack this neuroanatomical system that we've done a lot of work, not just us, but many groups around the world, understanding the network and what it is? Or is there something really special about placebo and beliefs? As you know, the placebo whole thing came with the sort of conditioning idea of Pavlov, ringing the bell and the dog salivating. The idea you can condition somebody to expect a certain outcome, and then you give them the saline pill or the sugar pill, and you'll get the same outcome because you've conditioned them, they've learned, they have expectation of a certain outcome, and that expectation alone will elicit the physiology. That's basically the sort of idea behind it. But unfortunately, it's got this very now bad press. The word, as you know, comes from to please. It comes from the mourners who were hired. They're called the placebos. They were singing certain Mass and Grace, and they were hired to be fake mourners at people's funerals. And so again, you can go back, and you've got in Chaucer here, the squire, placebo, the sycophant, medieval placebo mourners being dragged in and paid money to come and mourn. So it's got this terrible connotation of being fake, and that's the origin of the word. And again, subsequent to really the 1950s, when Henry Beecher quantified in the war, during formal placebo analgesic studies in the soldiers, that actually it was statistically, robustly, incredibly good, and it was clearly, evidentially true. That's when we threw it out of modern medicine. So there's a book review I've written on an excellent book by Walter Brown, which is Clinical Placebo and Practice. Sort of a bit of a going back, saying actually, now that we know that, which I'll show you in a minute, there's nothing special about it, why have we thrown it out of modern medicine since the 1950s? Because prior to that, it was actually extensively used. And again, many of our really learned physicians would write incredible articles in the New England Journal of Medicine, the Lancet, how to maximize the placebo effect. Because they understood it wasn't trickery, it wasn't fake, it wasn't delusional. You weren't doing it to catch out the patient. It was real. It actually did something neurochemically, neurophysiologically in my patient, and therefore why wouldn't I try to benefit from it? But once we quantified how good it was, we threw it out for the past 60 years, and then ethics committees came in, it all got very interesting. So the book review I've written summarised a little bit of the history if you want to go and read that, and then I'd recommend the book as well because it goes through it. So does it just hijack that system, Or is there something really special about it? Well, the answer is, I'm just summarising a couple of studies here, it hijacks the system. So this beautiful system in the brainstem I've described, when somebody has placebo analgesia, you can see activity in those regions. And indeed, that driver that I referred to at the front, you can measure the conversation between that driver and that brainstem system. And the more that conversation is strong, which we can see here, the more placebo you have. And if you give a drug called naloxone, which blocks endogenous opioids, you can block the effect. Yeah? And then you can go and you can do really fancy imaging in the spinal cord. You can just see this lonely little pixel here. There's beautiful studies done by Volk Eifert in Christian Buchel's lab in Hamburg, and Volk is now a postdoc with me. And what they showed here was indeed this system, this top-down system that I've explained should go down to the spinal cord and block those inputs so no comes in. Indeed, what you can see is lots of activity when you're experiencing pain, and then when you do a placebo manipulation and they think they're getting some cream with some analgesic in, you crush the activity. It completely goes. So again, beautiful proof in humans, functional imaging of the spinal cord, very hard studies to do, that indeed this thing really does just use that descending inhibitory system. There's nothing special about it, so why aren't we using it in modern medicine? It is a belief manipulation, it's an expectation manipulation, but it works, and it uses, again, these powerful systems of our body. So as I said, this was understood. Hippocrates, Galen, they understood it was really good to elicit a belief state, a trust state in your patient. Make frequent visits, ask about their symptoms. It wasn't because they wanted to trick them, it's because they knew that sense of togetherness, trust, caring, empathy, compassion did something physiologically in your patient that was really true and meaningful. Of course, they didn't have the measurements like I've got now to go and see what it is that they're doing, but they knew it because they were great clinicians, were great into it. And so the sort of interaction that happens in most therapeutic situations is the physician meets the patient comes in with all sorts of beliefs and expectations of their condition or what they might expect this therapy to do for them, because they've been trawling the internet, looking at Google or Wikipedia, or they've had experience of drugs before, or they've been doctor shopping and trying a few because they've not been satisfied with the consult they've had. So they're coming in with a lot of expectation and belief, yes? And that's not just sitting there doing nothing. That is driving very, very important networks and systems in the brain. And the physician then has a conversation, unfortunately contracting time more and more in the NHS, but they have a conversation. We know that patients probably only remember about 30-40% of what they've heard in the consult. So what on earth are they walking out the room remembering, I ask? And how does their disposition influence that? If you're an optimist or a pessimist, are you going to remember more the side effects? If you're a pessimist, the more the good things the doctor told you the drug will do if you're an optimist? How well has the doctor been able to manage your expectations and change your beliefs? Does it really matter? I would say it does matter hugely, and that was the hypothesis behind an experiment we did where we wanted to manipulate the expectation deliberately, mirroring what doctors do, in combination with a drug, a real drug that we use, a fast-acting opioid, to see how much does this influence the outcome? How much does changing people's beliefs change the outcome of one of our very, very powerful analgesic drugs? So that led us to do this study, looking at the effect of expectation or treatment expectation on drug efficacy. How do we do it? Right, we took a bunch of people like you, put them in the scanner, burn you away, that's the red line, and we're imaging your brain, and we're getting your ratings to how painful you find that. You have an IV line attached to a pump that can give a very controlled, solid dose of this very fast-acting opioid. We start the infusion, but we don't tell you we've started it. So we start it here, so it's called a hidden infusion. You don't know you're on it. You have no expectation, no belief that you've got drug. And then we burn you, we image your brain, measure your ratings. The anaesthetists go in the room, literally with the white coats on, the whole package, and say, okay, we're going to start the infusion now, check your blood pressure, check your heart rate, make sure everything's good, and you think, oh, fantastic, I'm going to get that great drug. Because we've given it you the week before, so you know how good it works. So you mount positive belief or positive expectation about the analgesia now you're going to get. You've already been on it for 15 minutes. You just didn't know it. So we burn you and we image your brains and we take your ratings. And then we go in the room and we pretend we're going to stop the infusion. So we're going to stop the infusion now, pay Okay, we'll be back again all the white coats, the whole package. The anaesthetists were marvellous, Oscar-winning performances, I would say. And they go in, and of course the subject at this point is, oh no, that drug's going to stop, it was fantastic, and they have what we call a nocebo, which is the opposite of placebo. So it's negative expectation, it's a belief that this drug is gone, it's going to be awful, it's going to be painful. And so what we were doing was seeing in the background of you've got the same nociceptive input coming in, you've been tonically on the same dose of drug, all we've done is change your expectation, right? And we're seeing whether that makes any difference to your ratings, and then we're looking at the brain mechanisms behind it. Right, what happened? Rating out of 100, 100 is excruciating, ethically we can't go there, obviously. 0 doesn't hurt. So you're about 65, so that's sort of moderate to strong pain. You know, enough where you've got your finger in the coffee cup and we don't want to take that out now. We start the hidden infusion, and what you see is you get 10-point drop. So you get analgesia because it is a great drug, but it's 10 points. We now then tell them we're starting the infusion, so positive belief and expectation kick in, and you get another 20 points for free. Okay, hands up if you think when we said we'd stop the infusion and they thought the drug was not being given to them anymore, they stayed at the same level of pain as here. How many of you think we reversed all that positive gain through a nocebo mechanism? Yep, that was our hypothesis too. How many of you think, actually, it went all the way back to baseline? Well done, you win the prize. They went all the way back to baseline. They overrode the IV dose of one of our most powerful analgesics through negative expectation and a belief that the drug had stopped. Now, from a pain point of view, that's sort of chronic pain patient. And again, I won't dwell on that because I want to give you a slightly different flavour of the talk. What the imaging is able to do is say, okay, did they catch on what we were up to and just gave us the ratings because they sort of knew what was happening? No, because the imaging shows the bits of the brain that activate switched off more, and then went back up. Now, they don't go fully back up to baseline, the ratings, and they shouldn't, because, of course, you've got a lot of opioids in your brain. It really is attenuating the processing. The behaviour, subjective reports, are driven by all sorts of factors. The biases, the influences, the negative expectation, the belief. So again, this is an important point for using imaging to tell you the truth about whether you've got, in terms of drug discovery, pharmacodynamic engagement, efficacy. Don't throw it out. You throw it out if you trust the ratings only, which is unfortunately still what we do, but the imaging is telling you, actually, that thing's on and it's doing something. And then, of course, we can say, well, what's going on in the brain that's driving that big positive gain? Because that looks good. That's better than the drug. So why don't we use that to treat our patients? And what's the thing that's hurtling them back to baseline? Because that's bad and we want to stop that. So again, one can do the analysis and you can pull out, surprise, surprise, our little driver, yes, in the front of the brain, talking away to the brainstem. The more you drive that, the more analgesia, free analgesia you get. And the more you drive this other little structure around your hippocampus, the more you're driven back to baseline. And this little area here, a very early work we did many years ago, showed when you're very anxious about pain and you think it's really going to be terrible, this is like an anxiety amplifier inside the brain around this particular structure. So it's very pleasing to see it was exactly that structure that was driving them back into nocebo. What about belief about controlling your pain? So this idea of, I can control my pain, or I can't control my pain, which is often the condition that patients will get into. How does that change your pain report? How does that interact and intersect with it? Well, again, a lovely experiment done by a colleague who's now working with me is this experiment, where she basically simulated different scenarios of a person experiencing pain where they could decide when to stop it. So they had the pain device on and then they could hit a button to say, I've had enough, stop it. And then the other scenario was they had the pain device on, but a computer in the room through there was going to decide when it stopped. And the third condition was you have the pain device on, but a person in the other room is going to decide when it stops. Now, unbeknownst to the person experiencing the pain, they were actually, their choices as to when they stopped their pain were yoked, so that it was when the computer did it and the person did it, they did exactly the same time period and level of pain as what the person had picked. So all you've changed here is their perception, their belief of whether they had control or not. The actual nociceptive input they were given was exactly the same in all three conditions. And I bet you can expect what happens. Pain ratings. If you control your pain, it doesn't hurt so much. It's exactly the same electrical stimulus was given. The moment you say a computer's doing it or another person's doing it, you're not so comfortable because you don't have a control of it. You have a belief that this is somehow worse. Anxiety goes up. And then again, one can work out these regions. Now, I'm leading up to our religious study, and I want you to just remember, one name of the brain region, and that is this very interesting little area called the ventrolateral prefrontal. It's very frontal, very high order, out there at the front and sort of to the side a little bit. Sometimes called the sort of anterolateral prefrontal cortex. And so this was the bit that seemed to be really, really interested and was more active in when you had self-control over your pain. You drove this bit versus the externally controlled. But here was the other really interesting thing about this study, is they phenotyped people to see whether they're a bit more of a control freak or not. I love working with psychologists because they've got questionnaires for everything. And so there are these questionnaires which measure your control freakness. And so you can either be a high control belief, so you're a very, what we call internal locus of control, or you are a very external locus of control. Religious people probably are more external locus of control. You tend to be more, okay, I don't mind, I'll let somebody else control it. That's fine, I've got a higher being, another thing I'm going to offer it up to, something else controlling, a benign God looking after me and controlling. So they tend to be a little bit more external, and others who are a bit more internal, maybe not. Again, it's not been formalised, that's just a sort of intuition. But as you would expect, if you are a high, self-control belief type person, and you're in that self-control condition, you really like that combination because you're controlling it. The moment you're flipped into the computer doing it, or the person, you do not like that situation. So in fact, you do worse than the people who, I don't care if it's the computer, a person, me, I'm not really bothered. But if you're a high control person, you see you've got two very different relationships. So you can either drive this region, or you absolutely inhibit it when you are put into a situation where you don't have control. And that's really quite important, I think, in the context of, again, some versions we have for people managing their own pain, patient-controlled analgesia with these pumps. Your intuition might be, don't give the pumps to those people who are really controlling, because probably that's a bad combination. That's exactly who you should give it to, because they're going to be much better. They're going to drive these systems, and they're going to get extra analgesia because they've got control. They do not like it when they're not in control. And again, all we're doing there is manipulating this perception, this belief of having control or not. Nothing was different in terms of what came in. So again, hopefully it's clear sort of how powerful the brain, mind, as Descartes would have it, can modulate processing. Now that little region, as I said, because it's a region that popped up in this situation, it was very interesting for the external locus. We hypothesized, and again, this region's been shown in other studies of emotional detachment, where you can just sort of detach yourself from the emotional importance of the event. So we hypothesized that this might be an interesting region, how when people are using religion as a form of pain relief, this might be the bit that is active because you're tapping into something that, again, you use as an emotional detachment area, you're giving it up, you're offering it up. So funded from the Templeton Foundation, we did this study. I'll put a little bit of Christmas theme here for you now as we're heading into the Advent season. And we did this study looking at religious-based coping. So what did we do? Well, we basically took a bunch of Catholics and atheists in Oxford and we electrocuted them. But in fact, there was a very funny Sandy Toksvig, that Friday night radio program. And when this study came out, and the press sort of were obviously very interested in it, I was driving home from work and I heard her talking about this. So I hear these people in Oxford, these scientists, have been doing this study, pretending they're interested in how religion and belief looks at that. And at the end of the day, they're just using it as an excuse to electrocute Catholics again. And it was very, very funny. Anyway, we weren't. We picked, we made sure that the people were very, very religious in terms of their practices, their prayerfulness and etc. They weren't just sort of signed up, on the certificate as Catholics. They really were very much, and the same for the atheists. So very, very well phenotyped, these people. They came into a study, and we did a study, it's a classic one called 2x2, called a sort of nude induction. So both groups see both sets of pictures. You see this beautiful picture of the Virgin Mary, which of course is very evocative, particularly, for a Roman Catholic. And then there's this other picture, which is Lady with the Urban. That's the picture that it is. And so both are seeing both pictures in a sort of design where you get to see the picture, you have the mood induction, we do electrocute you, and then we look at your galvanic skin response, we look at your pain ratings, and we're imaging your brain. And the hypothesis was that little region, which is about offering it up, external locus of control, emotions, attachment, when you're looking at that Virgin Mary, and that's a very symbolic figure for you, and you've used that in a very constructive way your whole religious life, it's probably changed you, and it's probably changed the way your brain, yes, reacts and activates in the context of seeing that picture as opposed to something else. And because you harnessed it for good, in terms of being able to offer up and take the suffering away and the pain and the benign and the sense of comforting, you're going to use that particular structure and activate it, and that will be the region, potentially, what we hypothesised, would drive the analgesia that we expected to see in the Catholics when they looked at that versus the atheists. So, did it work? Have you sort of understood the design, yes? Great. So, modulation of pain. What were the participants' ratings? Who chose analgesia? Is the first question. Turns out it was the religious, it was the Catholics, only when they looked at the Virgin Mary. So when they looked at that, they had significant analgesia compared to all other combinations and contrasts. And what picture did they prefer? Again, you might say it's a bias of the picture. Again, for the religious group, it was the Virgin Mary. For the atheists, it was the other group. And then, again, what was the sort of contrast and imaging of that? Again, if you look at the brain response to the same electrical activity, and they're looking at the Virgin Mary versus the other one, we see our little friend back again, that little region, anterolateral. When you do the reverse contrast, you don't see anything. So the capacity, and the more they engage it, we have a nice correlation too, which we tend to do in science. So we showed the more they could activate that, the more analgesia, in fact, they got. Now, the way we wrote that paper up was saying, actually, what we were looking at was a sort of more social neuroscience issue, that things that you grow up culturally with, of course, will change how your central nervous system is wired up, because that wiring up is happening all the way from birth through pubescent through to adulthood. So if you've been raised in a particular culture or a particular way, you're going to have a different central nervous system. This is not heretical to say that, and it's not rocket science either. But it's actually not an area that's particularly well looked at, certainly not back then, it is now. There's more studies looking at how different things about your upbringing make you more resilient or vulnerable in terms of your central nervous system. How well equipped are you to deal with the onslaughts that come later in life in terms of brain diseases? But this was a very early study at that point where we said, actually, if we were going to look at what a life experience might be that might change the way your brain is, and then put into a stressful situation like a pain, it might change how you react, which one would you go for? When you actually drill that down, there's not many you can control for in a sort of the boring way scientists have to. And religion is a big one. I think education is another, and I think the sort of parenting influence would be a third one. Actually, we found the religion was probably the easiest one for us to do an experiment on in terms of controlling the facets about it. And what we wanted to say in this paper is, although we've used religion, and obviously it's worked, it's generalizable to any belief state, any particular construct somebody might have, where they've used, in this case, a particular image, because it has meaning for them. And it's had meaning for them for a long period of time, whilst they've been developing these circuits, which are the circuits you're going to use and activate in these different situations that you might face, like having something like pain. And so it wasn't specific to religion, but it's specific to a belief. So the joke I'd often say is, for a real football Man U fan, you put David Beckham up, and potentially it would have a similar sort of effect. And again, I say that provocatively to stir some discussion, but hopefully you understand what I'm saying, is that I think some of these belief states, well, of course they're generalizable. I've just shown you it in the context of placebo. I've shown you in the context of changing the controllability, and here we have using outright, frank, religious imagery to, again, manipulate a particular belief state. Okay, the final one, I think on the last sort of 5 minutes, would be to, again, manipulate people's sense of threat or bias. So a sense that this might be more unpleasant, and how does that change things? So here's a fun experiment that, again, we did a few years ago. Probably shouldn't say fun, should I, when people are... Anyway, this is an experiment where we mostly took, actually, sort of people who were not from a biological background. We've got the luxury of these brilliant physicists and mathematicians in our lab. And what's wonderful about looking at them is, to be quite frank, they'll buy anything that you tell them about biology because they don't know much. So what they came in is, we came in and said, we're going to look at your skin, and we're going to, with this special machine, measure whether you've got a thick bit of skin or a thin bit of skin. We have this light. So, ooh, that's a bit thin. Mark that. It's a bit thicker. That'll be better. A bit thin. So we mapped it out. Total nonsense, obviously. They're lying in the scanner, and they see now the projection where they're told the orange ones are the thin bits. So that's going to really hurt, I'm afraid, when we burn you there with the laser. And the yellow ones, you've got the thick bits, you should be fine. All complete made up. It's just not true at all. But of course they feel threatened. So when they see the picture coming up and they see that, oh, it's the trial where I'm going to get my thin bit, threatened. It's like going into that dentist chair and coming in with the needle. And so what we were looking at is when we're giving them a stimulus that's just on that edge of, just painful, does it push them over the edge when they feel more threatened and they believe it's going to be on the thin bit? Well, I wouldn't show you if it didn't work because they say it did. So your decisions about how many events are painful, so in the going in for gold, the thin bits, they say more of them are painful, they're more painful, and they become more anxious. And all we've done is manipulated the belief of the threat of the stimulus. And again, then look at the neural basis for that. So hopefully I've just given you a sort of quick overview of how you can use imaging to not only understand how the brain works fundamentally, and that we're still working on, and as we develop new theories about the brain, that informs how we interpret things like pain. Hopefully you've learned a little bit about the complexity of pain and chronic pain, and how we're trying to understand that from a mechanistic point of view, but also how you could use these tools, I think, going forward more aggressively in understanding these slightly more complex experiences of belief states, and how, the standalone things like something, like a placebo analgesic state, but also more complex ones in terms of how do influences that have been very important to you, or very negative influences, how's that shaped you? How's that changed your central nervous system, such that you're equipped or you're not so well equipped to deal with, what comes our way later on? And again, going forward, that is a growing area, in the neuroscience sort of space and in neuroimaging. And so I would encourage you to look out for what's coming next. And then just remains to thank, obviously, all my fantastic, brilliant team who actually do all the work. And I get to come to lovely places like Cambridge and enjoy a few drinks and eat a nice dinner and chat with you all. But they do all the hard work back at the lab, and great collaborators, and of course lots of former group members as well. I'm meeting up with one of them tomorrow. He's an anaesthetic pain consultant here, so I'm looking forward to seeing him tomorrow. And of course I want to acknowledge our funders and all the volunteer subjects and patients that have been so gracious, giving us their time and their bodies and experiencing pain whilst we look at their brains. So thank you very much.
Thank you, Irene. That leaves plenty of time for questions. I'm sure that's stimulated lots of thought. So, hope you've got the microphone coming, so it'd be good to use that so everybody can hear.
Have you tried investigating acupuncture and hypnosis?
I haven't, but it's been done with imaging. Several very good groups have done some lovely work on the hypnosis side of things, and some of the early work and then the more recent work has done the hypnosis in two directions. They've hypnotized people to experience something that's not nociceptive, so a warm stimulus as painful, and then a painfully hot stimulus as not painful, and then worked out what's the brain regions that are involved in, again, driving these endogenous systems to pivot it one way or the other. There's not been imaging done that I know of, and I might, one doesn't know all the literature, but in terms of just looking at hypnosis as a state itself, that's a very interesting one that, again, is, I think, still to be done. And I think we've got different imaging tools I haven't mentioned here that allow us to look at the brain in these more tonic states, rather than having to look at it on and off, which is sort of how we've had to do the imaging for technical reasons until recently. Now we can use imaging techniques in a slightly different way, where we can just look at what does the brain look like in this particular state of hypnosis, and then not hypnosis. And so I think that type of study will be very interesting, because it's always been done in the context of pain, and so you've been focusing on the pain bit rather than actually what does hypnosis do fundamentally in the brain. It would be very interesting. The acupuncture, again, that just took a little while because of all the needles and metal, so you couldn't put it in the scanner. So basically it took a little while till people got acupuncture needles that were MR compatible. And there's been some lovely work done, if you're interested, with Tali Nakadao, a colleague in America, has done probably the leading work looking at the neural correlates of how acupuncture produces analgesia. And I think there's no doubt, still don't know mechanistically what it's actually doing, but it produces significantly measurable changes in processing that seem to be quite meaningful.
Thank you so much, that was fantastic. Can I push you on the David Beckham question, because I think it's the most interesting one. So, when you give someone a placebo, they have a reasonable expectation that it will be efficacious. And I wondered whether your thinking was, or their thinking was, that a Catholic person seeing the Blessed Virgin Mary might have a reasonable expectation of efficacious pain relief. Hypothesis one, or whether the hypothesis two, this is just someone who's very familiar, evokes a whole rush of memories and warm associations that is a non-specific distraction from pain. And it strikes me David Beckham would be a useful control there, because a Liverpool fan seeing David Beckham would have no reasonable expectation of efficacy in that situation. So what's your thinking around those two?
No, it's a great question. So let me just clarify. The placebo networks are the sort of powerhouse networks that, again, are no different to the networks we use in distraction and fight or flight and other things. That's pretty clear. The networks that you see are active when you were doing this particular religious studies, the more reappraisal, really interpreting, is different to placebo. So it's not a distraction. That's quite important to stress, but it's a different mechanism. So I was presenting two different neural ways you can have analgesia. One is through a very classic system, and then going forwards, these slightly more high-order complex ones where you're reinterpreting, you're reappraising, you are bringing that floodgates of what does this all mean for me, and how have I used that in terms of detaching the emotional significance of this physically painful thing, because I'm going to offer it up because I have a high external locus control. That's how we sort of hypothecated with the rationale for expecting that region to be honest. It's very different to that. And I think, again, you could go back and say, okay, well, if somebody really has used a David Beckham image in a very, supportive, comforting way, I believe that maybe they have. I'm an Everton supporter, so it wouldn't work for me. But if they have used that, then you would elicit the same thing. Or you could go to other religions. I think, again, it's generalizable to any state where you would ask the person to be looking at something that really has significant meaning, and that they have utilised and used in a way which has helped them in situations of suffering. And that, I think what we're trying to say is that's going to change you, that's going to change the way you're wired up, and we can see the consequences of that by doing an experiment on you in your 20s and seeing that, yeah, you activate that bit, and if you're an atheist, you don't, because you're just not using the same circuitry. So it's different to the placebo, and I think that's really interesting, that again you've got these different networks that one could potentially tap into. And we didn't go on, that was a really hard study to do. I think we've done a lot of studies over the years. I think it's one of our most elegant design studies. The results were stunning, and it was unequivocal, but it was very hard to publish that study. Very hard. So in terms of balancing one's postdocs careers and other things, to be honest, we moved on to other things, because I think either we were just too early in trying to push this sort of more social neuroscience type studies. I think we could probably revisit it now, and we have lots of follow-up questions we wanted to do. Take different religions, was it generic? It doesn't matter what belief state. Take it out of things like some other thing you might use that's not got a religious connotation. These are all the things we would love to do, but at that point we moved on to other things because it was just very, very, very hard. It was very interesting. People didn't want to touch it.
There's a question right in the back first.
Thanks very much. I learned a lot there. I thought it was really interesting. But I just had a question about the sort of experimental design, really, in your studies, because I was struck at the start by when you were talking about chronic pain, meaning that the system had gone wrong. And I was wondering whether the experimental participants in your studies, it may be too difficult to control chronic pain participants because they'd be already on different levels of medication and different types of chronic pain. But I was just thinking it would be interesting to have a comparison between people who don't have chronic pain and how they respond to the various stimuli that you're talking about, and people who sadly do have chronic pain. But I was thinking that, well, first of all, do any of your studies compare those? And secondly, how would you try to control for the various different levels of chronic pain and the various levels of medication that people with chronic pain would be on?
It's a great question, and you're absolutely right. I mean, the approach that we've taken in terms of trying to understand pain in the healthy nervous system, so just to understand it as a neuroscience question, then in the acute warning system, and then in the chronic, is to build a very solid foundation of the underpinning mechanisms and the networks and the physiology and the neuroanatomy, to then challenge those networks in all these different contextual situations of changing the mood, so that we've got a really clear understanding of what regions anatomically are involved in driving that. And then, of course, because I'm a translational neuroscientist, we want to take that into the chronic pain condition. If you go straight to the chronic pain without really knowing what you're looking for, you're stamp collecting a little bit, and you're not going to help chronic pain patients. So our approach has always been to get the basic science right, and then see how that translates into the chronic pain condition. So once now, and we've obviously been on that journey for a long time, we've been imaging for 18 years, different cases. So we have lots of different experiments looking at different types of chronic pain patients, where we're sort of at the point of replicating what we're seeing in the acute pain piece to see which bits are involved, which bits are more involved, which bits are we surprised we don't see on, and then to again take them into often some drug trial related work where naturally they're going to be on a placebo arm actually. So in fact we've just finished a trial in patients with nerve injury pain where they've come off their current medication. That's one way to approach that confound. If they're willing to sort of have a bit of a drug-free holiday, which sometimes the physicians do anyway to see where they're at, they can then be randomised onto, again, in this case it was 2 different drugs and a placebo arm. And then what we've shown in this study, we've really just submitted it, is that, and again it's a nice proof for the first time in chronic pain patients, in a chronic administration of placebo, not just acutely in the scanner. So over a week from placebo, they drive the same mechanisms as what we've shown endogenously here. And then there's some other really interesting things about what the drugs do to that placebo mechanism as well. So that's the approach, is to slowly take it, because you're absolutely right. If you go straight in, there's just too much that's heterogeneous, and you're not going to get clear answers from that. Now, in terms of taking chronic pain patients and doing more challenging studies, in terms of looking at, again, how other types of interventions they might be using at home, in terms of hypnosis, mindfulness, using religion, music, these are all things that, again, labs like mine who work in pain are absolutely determined to do, and it's on the list, and we'll just get them there eventually. Does that answer your question?
Yeah, thank you. Yeah.
Great.
Well, another one, I suppose, might be homeopathy, which is extremely controversial. Of course, there's a move, of course, at the moment to get it abolished in the NHS, but maybe that might work like a placebo, and if people are convinced that it's going to work, yeah. And for chronic pain, I mean, you want people who've got a cancer tumor to be treated conventionally, obviously, but if they've got chronic pain, rheumatoid arthritis or something.
Yeah. So I mean, there's now Ted Kapchuk. He's a placebo researcher in the States, and Ulrika Bingle, who came and worked with me to do that study where we manipulated expectation. She's a neurologist back in Essen now in Germany, and she's been extrapolating that result to, again, a chronic setting and showing it just gets more and more hardwired the more you sort of maintain the sort of negative expectation. But some various consortia of placebo researchers, including Ted Kapchuk, what he's done is actually he's done a trial that's really fantastic. He's actually taken patients with irritable bowel syndrome, a very painful condition, and he says, right, I'm going to give you this pill. It's a placebo pill, but here's why it's going to work. And he shows them the imaging and the science, the networks, and this is what you do. So if you go through the ritual, and you use it, and you believe in it, you will drive those systems and you'll have analgesia. And he gets, the data is, now it's not the full Monty of placebo, it's not the full sort of manipulation of expectation, but it's still significantly better than none. And so I think, again, going forwards, you know, can't really comment on homeopathy, I have no exposure or experience to it, but, you know, using in our armamentarium, in the absence of drugs that aren't working that well, when you can see, you know, double the analgesia for free, and you just have to get people to work out how to switch on these systems, why aren't we somehow incorporating that in modern medicine? Because we're, you know, it's not right. And similarly, why are we not incorporating things that are on the nose, taking away the things that we know are producing nocebo, blocking patients from having analgesia because they've got negative expectations and negative beliefs about their pain. This is really holding back drugs from working, and my biggest worry is potentially then people take the drug away because they're not getting the analgesia, and because you are only relying on the report, you might be missing the fact that the drug was working, it was on target, it was calming things down, it was fixing things, it was doing what it should. The reason the person's not reporting any analgesia is because there's other things that's keeping it up, and you need to understand that, and that's a real concern for me, I think, in the pain field, is that our over-reliance on the rating means that I think sometimes we're missing and decisions are being taken that might, you know, not be optimal.
So at the front and then at the back.
Hi, yeah, I'm going to follow up the placebo question we had over here, but from a slightly more historical, maybe even religious perspective. I was very interested that you mentioned that Galen and Hippocrates had a clear intuitive understanding of how to make an efficacious treatment of people that was in their care.
Yep.
I'm just wondering if you could make the same reference to Christ. It's well reported as a healer in Luke, it's touched on in Mark in great detail in a very personal way, and also in John. But one of the things that's well recorded is this phrase, I will send you the Comforter. And it's been interpreted in many religious ways, but in the context of an understanding of, you know, a placebo capacity, would be a reasonable assumption
Yeah, I
to make
think that's
about this person.
Yeah, it's a great, I've never thought about it, which now you mention it, it seems sort of obvious. Yeah, and I think that's a very interesting connection to make. I mean, this sort of sense of, you know, as you say, the comfort, the trust, the sense that somebody's going to look after me, you know, and this will be better. I mean, you could go back and say also back in the day, of course, everything was placebo because all these lotions and potions, there was no pharmacy understanding of what the drugs were doing. Everything was given on the faith that works. And to be quite honest, we have quite a lot of modern medicines where there hasn't been formal testing against a non-intervention arm.
At that time, we would be cutting edge.
Yeah.
There would have been no history.
Yeah.
Looking at the Virgin Mary, you've got a whacking great lot of
Indeed.
history behind it.
Yeah.
But at that time, you were so far ahead of the curve, it was untrue.
Yeah.
It was in the face of batch pain.
Yeah, I'm sure there's an element to that, and the sort of charismatic nature and those sides of it. You know, I'd agree. Yeah.
In the middle.
Thank you. Thank you very much for a very interesting and informative talk. With the power of the placebo, do you think that randomized controlled trials could actually compare the trial substance? Would it be better to have 3 arms to it? A control, a placebo, and nothing? Because the placebo, in effect, is actually, if you like, as far as the brain goes, it has an active ingredient between the ears.
You are like a plant. You said exactly what I would say. It's like, often we'll teach, it's like squirting an opioid in. You know, you're giving a drug, it's a real thing. It is a real, you know, neurochemical release of stuff, you're driving networks. So it is an active arm because it's an active manipulation. And I think, you know, the frustration I have, I do a lot of advisory work, you know, for the pharmaceuticals. I think people's understandings, this is no criticism, I think it's just where the science has come. I think there's a big gulf between what's understood in the cognitive neuroscience world about placebo mechanisms and how people use that word and understand it in a clinical trial setting. These are two quite different worlds. Now they're coming a little bit together. So part of that placebo network that I mentioned Ulrika Bingle is putting together is to try and inform clinical trial design and people's thinking about randomized trials and these issues of what really is the placebo arm based on solid science. And so you've got to think of it as not the inert arm, it is an active arm. So you have a complete non-arm, you have a placebo arm, and you have your drug arm. Now let me just expand that a little bit more, because again we've done a lot of trials using these different things. So one, again, if you take pain, you know, as you know, it's got the worst record for drug discovery. Every drug fails. That's the whole other lecture as to why that happens. But one of the things is what is going on in our clinical trials as to why you never can beat the placebo arm. So again, some of the data I've been saying that we've just been preparing for submission shows that when you've got a drug, your active drug, your control drug that you want to see what it's doing compared to placebo, if it's a very brain-based drug and it's in the brain, it's binding to lots of things, well, maybe it's binding and switching on and off networks that are important networks that drive the placebo response. So the assumption, for those who, sorry to sort of use jargon, but there's this thing called an assumption of additivity in randomized controlled trials, and that is to say that everything that happens on the placebo arm happens also on the drug arm, so we subtract everything we measure on the placebo arm from the drug arm, and then whatever's left over is how the drug works. That's your classic design. Well, what if that drug arm messes up your capacity to drive the placebo response, and you didn't know it because you weren't doing imaging and seeing that, you were just using ratings? You would subtract out too much, so the placebo isn't now working in the drug arm. So you take away too much and you kill the placebo. But it's a drug that's actually, I hope I'm not losing people, you want analgesia, right? You want to get pain relief for the patients, but you also want to fix the thing that's gone wrong. Now I can give analgesia, I can do it with placebo, so you give a drug. Change the physiology that's gone wrong in chronic pain. No, it's going to give them analgesia. There's not. So the drug's on target, it's calming things down, it's working, and you get some analgesia. Placebo arm now doesn't work on that. I'll take that drug because it's fixing the thing that's gone wrong. Certainly in the pain field, it's all about the rating at that time. The assumption of additivity is questionable in certain conditions. It might not be true. And again, we have some data to support that in conditions where you have a drug binding to the brain, you don't see the placebo network on as you do on the placebo arm. So I'm a big fan of, to really unravel that, as you say, you are not going to have anything, and you just see what activates. You are going to have a placebo, and you see, right, they go from 10 points down to 8, but it's because they're driving the placebo mechanism. And then I've got my drug arm, and I see they've gone from 10 points to 8, but actually it's switching off all these other bits that have gone wrong. And that is hugely informative. And right now we'll throw the drug out because it didn't work, because we're only looking at the 10 to 8 point drop. Does that answer your question a little bit? So sort of where we're at in sort of our imaging of design and how, again, informing clinical trial design, it's a sophisticated discussion point right now. I know you can imagine there's a lot of controversy and discussion and different views on it, but the science keeps coming and we'll keep progressing.
Well, thank you. I think we'd better stop or we're not going to drink. But I'm sure Irene will be very happy to keep talking over refreshments next door. So there's going to be an announcement from Hilary.